Morning, everybody. I think that last panel did a great job of setting us up for this panel. We've talked a lot this morning about policy work and some great work and great changes that are happening. We're going to shift the gears a little bit and talk about what's working in treatment for all of these problems. And as the last panel said, the brain research has propelled the science forward in finding effective treatment strategies and interventions. So we're going to hear about some of those this morning. And we'll start with Dr. Russ Kamer. He's Chief Medical Officer from Partners in Prevention in New York. Tom Wolf is the founder for the Pacific Alliance for Prevention and Recovery in San Francisco. Albert Black is the CEO and owner of Recovery in the Pines in Prescott, Arizona. And John Puls is the owner and founder of Full Life Comprehensive Care in Boca Raton, Florida. So gentlemen, thank you. I'll give you a chance to talk just for briefly about yourself and what you do, and then we'll launch into some questions.
Sure. Morning, folks. Just want to thank Luke and the whole SAM team for putting this on. So I'm a licensed clinical social worker and psychotherapist, also a master certified addiction professional. People often ask, how I got, so passionate about working with families and individuals impacted by cannabis use disorder and cannabis-induced psychosis. One of my first cases as a baby social worker going through undergraduate, there was a young man, 19 years old, who had no history of psychosis in his family or himself, was at a prestigious university, had a psychotic break from cannabis, came down to Florida for treatment, and subsequently tragically died by suicide in a psychotic state. And I remember speaking to the psychiatrist at the time, and he said, this was from a cannabis-induced psychosis. And I was like, really? I didn't quite buy into it. I was 25 years old. I didn't recall anybody ever experiencing that, but I went and researched it a lot, and so now it's something that I work with on a daily basis with families and individuals across the U.S.
Hi, my name is Albert Black, and I'm, I'm the founder and owner of Recovery in the Pines in Prescott, Arizona. I never thought I would be sitting up here, but I'm an addict, and 14 years ago I got sober, and thank you. And the town that I lived in was one of the top 10 treatment communities in the country, and what I saw was despicable. And so I decided to open up a treatment center. I'm a business guy. I owned a real estate company before this, but I'm the guy. And so I'm really passionate about what I do. I have intimate knowledge about what it takes, and I just see a lot of bad treatment. I saw a lot of bad treatment then. I see a lot of bad treatment today. I know there's parents in the audience that have lost loved ones, lost their children. That's what we're talking about. All of this, what we're talking about, the real story is the parents that have lost kids. And so, they just go to treatment after treatment after treatment, and nothing changes, and some kids die. And I want to stop that, So I'm up close and personal with that. I'm passionate about what I do. And again, thank you.
Thank you. My name is Russ Kamer. So the main things I do, number one, is that I am a primary care physician. So I take care of patients as regular patients. So I've seen my patients through, whether to refer them to treatment. I have plenty of patients who are in recovery. And number two is, as the medical director, co-founder of Partners in Safety. Partners in Safety, we do occupational medicine, a lot of physicals, drug testing, and monitoring. So we have clients who send people over who may have tested positive. I refer them to treatment, or other people refer them to treatment. And then we monitor them. So we have an idea of the success, and most people do succeed, and those who don't succeed as much. One thing I want to mention before we get into the prevention, or really to treatment, but prevention comes first. So I should put prevention first. Is the worst thing, we've talked about it all morning, the worst thing that happened, the absolute worst thing is this idea that marijuana is medicine. Okay? Just saying the two words together annoys me. Medical marijuana. Never say that, never say it. Never say medical marijuana, because all it does is subliminally reinforce the idea that marijuana is medicine. And this affects people trying to recover, affects preventing people. As I say, we do drug testing. 30 years ago, when someone tested positive for marijuana, nobody said it was their medicine, okay? They went to a party, they were at a concert, no. Then, for a while, in the medical marijuana cards, they'd say, well, I take it for my back, and I don't want to take opioids, and it's for sleep. Although I have to say, in New York, now that it's legal, it's gone back to, well, it's legal. So at least they're being a little more honest and not pretending that it's medicine. So anyway, go ahead, Tom.
Good morning, everybody. My name's Tom Wolf. I'm the founder of the Pacific Alliance for Prevention and Recovery. I'm also director of West Coast Initiatives for the Foundation for Drug Policy Solutions. But more than anything, I'm just a grateful addict in recovery. I'm almost 8 years clean and sober from heroin and fentanyl addiction. And I was also homeless. I actually was one of those guys you saw in the videos in San Francisco in the Tenderloin. That was me. I was that person in 2018. So what I focus on is I focus on the intersectionality between drug addiction, homelessness, criminal justice reform, and the policies that we are taking at a local, state, and national level, which have been pretty much abject failures across the board in almost every state in the nation, but especially on the West Coast. California, Oregon, and Washington have 55% of the nation's homeless population. According to a 2019 study by UCLA, 78% of those people are struggling with co-occurring disorders of addiction and mental illness. And the treatment opportunities that we have for people not only are lacking, but they're rooted on the West Coast, again in California, in what I call permissive harm reduction policies. Whereas, for example, you go to a 90-day treatment facility, you walk in, and next to the front desk, there is a tray with foil, pipes, straws, so that and clean rigs, needles, so that if you do decide to relapse, you can do so safely. I mean, look, as someone that was a former intravenous drug user, if I walked by that every single day, I think that might be a trigger for me. So we need to improve our treatment modalities. We need to improve access to treatment. We need treatment on demand. I fight for those things. It starts with stabilization, detox, residential treatment, and then post-treatment recovery housing. I fight for all of those things. And we also need to find new opportunities to reach the other 90% of people struggling with addiction or gambling addiction or marijuana addiction that never seek treatment. How are we going to get to those people and offer them help? And I'll talk about that a little bit later. Thank you.
Well, thank you. This is truly one of the most complex problems that we have to solve in this country because there's no single solution. There is no silver bullet. There is no one single approach. It takes all of those things. But I also want to come back to Albert and John and talk a little bit about what you all do that these two gentlemen on that end talked about and didn't bring some of your work into the spectrum as well.
Okay. Well, when I got into opening a treatment center, treatment doesn't work. You're going to find that odd that I'm a treatment center owner and I'm telling you that treatment doesn't work. It doesn't. The success rate for treatment is less than 10%. That's not a good statistic, but it does work if you do it right. And I've yet to see a plan. You know, our program's 6 months to a year. 30, 60, 90 days, that's a lie. It's an absolute lie. Yes, I know there's a few people that's happened to, but most don't. And so I think it's about educating parents and really telling them what it's going to take. I get calls every day, and everybody wants to get back to school. They want their kids working. They want all these things, and it's like, that doesn't matter. It's like, we got to start having honest conversations. You're dealing with a monster, okay? And I know when I got sober, I was 45 years old, and I asked for help. I mean, the writing was on the wall. My wife was, done. And they told me to close my business, not work for a year. I was taking off all our bank accounts. That's what I needed to do. Everything needed to be stripped down, and that's what it takes. But most people aren't willing to do the work. I mean, I get calls from families, from successful parents, high earners, educated, and they're trying to solve this problem, and they can't. It's not about being smart. It's about doing the work with someone that knows what it's going to take. I have intimate knowledge of what it takes. These gentlemen do too. And so we got to start with long-term treatment and really showing people what it's going to take.
Yeah, and I think Yeah, that was very,
Can I just say something?
yeah, of course.
And John just, he referred a patient to us, so, you know.
Yeah, and I think to Albert's point, and I'll expand on it a bit, is that I think we have an issue with access, right? So if we look at the amount of people with a substance use disorder or cannabis use disorder in general, a very small percentage of them actually even are able to access treatment. So that's a huge problem. And what I really see often with families that have cannabis-induced psychosis, people with cannabis-induced psychosis as loved ones, is that they keep getting the door shut, right? So they call outpatient providers and they say, we can't help you because it's too acute. I don't work with addiction, I don't work with psychosis. Okay, then they call inpatient providers and they say, oh no, we're an addiction treatment program, we can't work with somebody with psychosis. And they call a mental health program and say, oh, you know, they're too psychotic. And then you call law enforcement, you want to get them hospitalized, and the law enforcement says, they don't meet the strict criteria for involuntary commitment, so we can't help you either, right? So it's door after door after door being shut for these families. I'm seeing a lot of heads nod that have experienced this. And so, you know, I'll use a term from Albert when he talks about working in the trenches. So, you know, in South Florida, where my practice is, although recreational cannabis is technically illegal, everything else isn't. And it's, you know, very accessible to everyone. And so we are constantly getting phone calls, and I'm constantly actively working with people that are, you know, that are psychotic and experiencing the cannabis-induced psychosis, and there's so few programs for people to actually get support from. So what ends up happening, they say, call SAMHSA, go on the SAMHSA website. What a crapshoot, right? I mean, that's, especially for a family that doesn't know what they're doing, you know, really dealing with, you tell them to call SAMHSA. I mean, that's not gonna work out. And so we really have a shortage of access and then like more quality long-term programs that is also prohibited by managed care, right? You may have a family that has, they have a great insurance policy. They're finally trying to get their loved one into treatment. Well, you got a $20,000 family deductible, and you know you have your co-insurance that hasn't been met, and it's so difficult for these families to not only find quality programs, but to be able to reasonably access it. So those are the two biggest things. And I'll add too that we know from research that longer term treatment helps. There's so much focus put on the short-term inpatient, right? Make it as nice and comfortable, qualified people, but what happens after the 30, 60, 90 days? And to Albert's point, I really view this as a problem of aftercare. Where is the adequate aftercare support for these families? Where are the specializations that are educated to work with this? And I will tell you a little glimmer of hope. When I first started doing cannabis-induced psychosis and recent trends in cannabis use presentations, one of my first one was at National Association of Social Workers in Florida. And they accepted my presentation submission reluctantly. And they, you know, in a lot of conferences, there's different rooms depending on what they think people are gonna register for. They put me in the tiniest room possible. But I'll tell you what, it was completely packed. And it was really hot because they're bringing in other chairs. So there were a lot of clinicians that really wanted to learn about this, and it came up to me afterwards. So a little bit of glimmer of hope there.
Yeah, I think we talk a lot of times about what it takes long term. And this is a problem because it affects so many aspects of your life. And usually people have destroyed a lot of their relationships and a lot of the things of stability in their lives before they ever make it to the treatment door. And so part of that, as Tom said, is how do we help them get those things back in their life? And that takes a good year, at least, to restore their families, their relationships, their jobs, their place to live. All those things are critical for long-term recovery. If we think about this from the heart attack perspective, you know, we do long-term care for heart patients all the time with a lot of support. Put them immediately into a rehab program and keep them coming back for that first year so they don't relapse and have a second heart attack. We need some of that kind of thinking when we look at funding and solutions. Dr. Russell, you want to add to that?
Right. So, clap, clap. No, that's a great analogy to the heart attack, because I was at, and this was just before the pandemic, so 2019, New York State, the politicians were having little get-togethers about what to do about the opioid crisis. And so what they really were pushing was to put everyone on Suboxone. This is what they were pushing. And their idea of treatment was, okay, and they were talking, I presented, there was some other medical professionals, treatment professionals, and they would say, well, the doctor, if someone comes in with an overdose, they get treated. Now, all they needed was to get, let's see, they get a Suboxone prescription and then go to their primary doctor who's going to fill their Suboxone prescription. And I'm not kidding.
Right.
So, but it's like you say, and what I didn't have the wherewithal to say at the time is, well, that's like telling a heart attack patient, okay, you recover from your heart attack, here's your Lipitor, go out there and have a good time. No, you need comprehensive care, whether it's a 12-step program, group therapy, whatever it takes. This is not a pill. And I was just reviewing, and things have changed because when I was a student, I remember we were taught that the best treatment for alcohol was AA, right? I was at Columbia, and we were in the New York State Psychiatric Institute. They brought in someone from AA to talk to us about it. And our professor said, you know what, we don't know how it works, but it works. Now, I was just reviewing my text, the latest thing, and yes, they still, mutual help, blah, 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 medication. But there was a news flash, new treatment, transcranial magnetic stimulation. Okay? This is a new treatment. Like, leave it to the medical profession to come up with the most expensive, ridiculous thing instead of AA, which is free. So, this is a trend, but we know it helps, and it's comprehensive. Yeah, Tom.
So two things. So one, part of my work in San Francisco is kind of, I joined forces with an already existing recovery coalition in San Francisco. Now we've grown it to over 500 members of people in recovery in our community that want to recover out loud, right? So in 2024, we held a big recovery summit in San Francisco. We had 500 people come, the mayor, the future mayor, all these politicians. We're going to hold another one this September to push the agenda, to push the idea that recovery requires community, it requires peer-to-peer support. And, no offense to any doctors in here, but many of us in the recovery community kind of feel like recovery got hijacked by the doctors, okay? Where it's like, here's a pill, here's some Suboxone, here's your clinician over here, go to your outpatient treatment, you're all good. When what they really need to do is they really need to find their community. And that's what the recovery community is. It's like, we're your people, It's like, I found my people in the recovery community, and they are the ones that help support me. Did I use buprenorphine when I had to go to jail for the last time to get off of the fentanyl? Yeah, they put me on a 5-day taper, and I haven't touched a drug or a drink since then, right? So is medication assistant required for fentanyl? I believe it is, because fentanyl's so strong you can't kick it cold turkey. So let's not pretend, okay? But we need to have a working partnership where we have the community, we have peer support, we have 12-step programming, all of that wrapped in so that doctors and academics aren't making all the drug policy decisions, because that's kind of what got us in trouble. That's part of what got us to where we're at today. Mix that in with kind of this permissive or radicalized harm reduction approach that you see on the West Coast. Mix that in with criminal justice reforms that you see on the West Coast, where we reduce quality of life crimes for open drug use, let's say, on the street. Those are the kinds of things that are plaguing cities, and frankly, at one point, about a year and a half ago, brought San Francisco finally to its knees, where we surrendered and we changed course, where we actually passed an ordinance in San Francisco earlier this year to change our city, not earlier this year, late last year, from a harm reduction drug policy to a recovery first drug policy. It's an actual city ordinance that we passed, right? Because we recognize the power of recovery, and what people really need is treatment, and they need opportunities, not just here's more crack pipes for you, because that's kind of what this whole thing has become. And it's reflected in the overdose deaths on the street, 650 in San Francisco last year and the year before that, okay? And while overdose deaths are still declining, they're still one of the highest in San Francisco. We're at 88 per 100,000 people dying of drug overdose every year. That we haven't really solved the problem. We've just kind of swept it inside, and now 70% of the people are dying of overdose inside. So we still have work to do.
Yeah, John, you were very passionate a few minutes ago talking about just the psychosis that many of you, unfortunately, have experienced with your loved ones with that problem. And that's a new problem that really has us all kind of struggling a little bit. So what have you seen that's been effective in helping either advocate better for treatment, dealing with that problem, or just the treatment itself that's working?
Yeah, absolutely. So I think one of the most complex things about somebody that is currently psychotic is that it's something called anosognosia, where they don't understand or believe that they're ill, right? They have no insight into it. And this is much different from denial, right? So I'm also, in long-term recovery. I may have been in denial about the severity of my addiction, but I did in fact know I was using drugs. Right? That's the difference. Somebody that is experiencing, psychosis and is flirdily psychotic does not have any insight into their illness, and it's as real often as I am talking to you now, right? And so to try and convince somebody that they have something that they have no insight into having, and perhaps trying to get them to medicate or to stop using the substance that's causing the psychosis, is incredibly complex. And this is where I get into murky waters with a lot of folks, but what I found, quite frankly, is often necessary. And listen, there's tons of methods you can use. There's the LEAP method, Dr. Amador, listen, empathize, agree, partner when you're trying to work with somebody with psychosis. But sometimes that can only get you so far. And in my experience, I've had to, unfortunately, initiate a lot of involuntary commitment proceedings against people that are having, severe psychosis. And this is where we get into the civil liberties debate with a lot of people, right? And, the cost of taking away somebody's freedom of movement in order to treat them. And I think that a lot of people have a difficult time with that. But frankly, what I found is that if you have no insight into your illness, you don't understand that you're sick, and we know the rate and the risk of somebody in psychosis, that they're at a much higher risk of dying by suicide or harming themselves or harming someone else, we have to be willing to protect them. And that often may mean treatment over objection. And fortunately, I live in a state where it's easier to initiate those types of proceedings, but in many areas, it's very, very difficult. And so, the short answer to it is approaching somebody that's in an active psychotic state. They may, and you don't know if they're going to clear up. I've worked some cases where people are only psychotic after intoxicated using the substances. Worked plenty of cases where people develop persistent schizophrenia. They need long-term antipsychotic medication. It really just depends. But I think the first thing is trying to get them stable and keep them safe.
Albert, what can you add to that from your experience or from people you work with?
Just being in the trenches, I'm listening to all this information. We have so much information. We can tell you why everything happens, but what's the solution? And so, again, back to treatment, it's like we have to stabilize people. And so everybody stabilizes people. You can go to the ER today. If someone's crazy, we're going to send them to the ER. We're going to send them to a detox center. We're going to stabilize you. I think everybody does that. And then what we do is we educate you. So you end up in treatment, and we stabilize and educate. That's where 99% of programs stop. What we need to do is stabilize, educate, implement. So the things I'm teaching you or talking to you about, I need to see you start to practice. And then what that does is that creates new habits. So we got stabilization, education, implementation, what I'm teaching, and then I need to see habits start to form, which creates a new purpose in life. That's a program. That's a plan. And so, 95% of our patients come in over-medicated and misdiagnosed. That's what our medical community does. Everybody's on a pill. Everybody's bipolar. Everybody's depressed. Everybody's whatever they are. And what I know is that, 95% come into our program over-medicated and misdiagnosed. Almost 100% leave off of everything. I believe in abstinence. Mental illness does exist, but not at the rates that doctors are dispensing medication. That's just a fact. And so, again, long term, I hate to keep beating that drum, but the things we got to do, I'm not changing anybody's life in 90 days. It's not possible. And so we got to go through all those processes. And a lot of times people will say, well, I'll do it when I get home. It's like, no, you won't. I need to see you do it here. So I get, 90% of our patients failure to launch, the 18 to 35-year-old, the parents are still taking care of. That's wrong. And so that's part of the problem. But we got to see them do it when they're in our program. You got to work when you're in our program. You got to go to school when you're in your program. You got to be self-supporting. I tell parents, I know you can buy a plane ticket for him to leave, and you can get him an apartment and a car and do all those things. He needs to leave on his own. Like when you call me, if that's not your plan, that he leaves here on his own, gets a job, saves money, I'm not the guy.
Thank you. Okay, lightning round real quick. We just have a few minutes left, so I'll give each of you just about a minute and a half to what's the thought you want to leave this group, and the one thing you really want them to hear when they walk away.
Two things. One, recovery is possible. Every single human being on the planet that's addicted to drugs is capable of recovery. They just need to be given the right opportunity to do so. I want to make that clear because too many people are waving the white flag saying recovery is too hard, so we should just support them. Here's more drugs for you. That's what they're doing in Canada, folks. Okay, so with that said, also, I love what Jim Crotty was saying earlier. Social media should be our friend, not our enemy. We need to make it into our friend. I have my entire platform was built on social media. I reached 44 million people last year on social media, using it for good, for recovery, okay, and for changes to drug policy. AI, we can make that our friend too, because if we try to stop it, China's going to do it anyway. So we might as well lead the way. Of course, I live in San Francisco, which is the headquarters, that's the AI capital of the world. There's a sobriety app that I work for an AI company that does a sobriety app called Sunflower Sober. And it has a virtual AI sponsor, and it has a chat, community chat. It's HIPAA compliant. They've got all the guardrails that ChatGPT doesn't. It can be used for good. We have to start thinking about the future and the evolution of treatment and reaching the people that don't come forward and say, hey, I need help. Thank you.
Yeah, I'm just going to echo what Tom said, that recovery works. There is a lot of pessimism, and I think it's based on the people where the clinicians may see the people, whether at the beginning or different populations. But from where I sit, I see a lot of people who succeed. And I know for a fact that when we have a big union in the Northeast, people have good paying jobs. They have CDL, commercial driver's license. So after they've gone through treatment, we're monitoring them. And most pass, most will, yeah. There's some problem children that need extra attention, but most people do well. But this pessimism, to go back to what it used to be and what it is now, when I was a medical student at Harlem Hospital, I remember first being told, is once an addict, always an addict. And echoed recently of a doctor in New York who's does treatment with medication, primarily medication-based, was very pessimistic. And Kevin was on that call, and it's hard to believe that there's this much pessimism, which leads to the harm reduction, a gentler way. Just give them some free crack pipes and needles, and that, because people want to control the climate, but they can't control their own behavior. So it works. Good.
Just want to give you hope. I think there's 3 guys up here that got sober, so it is possible, but it's going to take time, it's going to take commitment, and it's going to take work. It doesn't just happen.
All right, thank you.
All right. So the last thing I would want to leave you guys with is just this idea of community integration. So I think that from a treatment perspective, where things really lack is integrating families and their loved ones who have some type of substance use disorder, cannabis use disorder, cannabis-induced psychosis back into the community. And we have to be willing to remove the traditional barriers of treatment and go to people in the community and meet them physically where they are.
Okay, thank you all very much. There's some very good insightful things on what you can advocate for.